Welcome to the deep dive. We often talk about logic models, like blueprints, right? To see how healthcare improvements should lead to better outcomes.
That's the idea, yeah.
But what happens when the improvement itself isn't fixed? When it, changes depending on where you put it.
Exactly. That's the crux of the issue we're seeing now.
So today we're diving into why those traditional logic models might be facing a bit of a complexity crisis in healthcare research. And we'll explore a potential new way forward.
That's right. For years, especially after the 2008 MRC guidance came out, there was this big push for process evaluations. We really wanted to understand the theory of change.
So not just if something worked, but peeling back the layers to see how it worked, getting under the hood.
Precisely. It was a significant step. But, healthcare interventions have gotten more complex, more adaptive. They're designed to fit specific places. And now some experts, particularly in medical education and research, are asking if those established methods, well, if they really capture the full picture anymore.
And this is where it gets really interesting for anyone involved in healthcare improvement, isn't it? Because implementing something standard, like a new drug protocol, that's one thing.
Great.
But what about when you're trying to change behaviors?
Wow.
Or complex social dynamics within a hospital ward? That feels different.
It is different, and some researchers argue the original guidance might be better suited for what we could call complicated interventions.
Complicated.
How so? Think of things that work pretty much the same way wherever you do them, like introducing a new surgical technique. There's a clear protocol, it's intricate, but it should yield similar results across different settings.
Okay, defined steps, predictable results, mostly.
Exactly. But complex interventions, they're aimed at changing social systems. Their actual form can be molded by the context they land in. There are feedback loops, adaptation.
So the people delivering it learn and adjust as they go.
Yes. Take a program trying to improve communication between nurses and doctors on a ward. The facilitators won't do the exact same thing everywhere. They'll adjust based on past experiences, the specific ward culture, the existing relationships, even the workload that day. It's constant tailoring.
So the intervention itself becomes, fluid, shaped by its environment. That must be a headache for traditional evaluation methods that kind of like things neat and tidy.
It is a major challenge. And this leads us straight to logic models. These visual tools, diagrams usually, that try to show the theory how the intervention should work. They simplify reality.
And people like them because they offer certain benefits, don't they?
Oh, absolutely. Proponents say they help understand cause and effect, organize data, figure out what to measure, get stakeholders on the same page.
Consensus building, yeah.
Right. And they're useful for showing funders the logic or sharing lessons learned.
But as we're saying, the big critique is that they often skate over that crucial interaction between the intervention and the messy reality of the context.
That's the heart of the debate now among researchers and medical educators. Some feel like our standard logic models have sort of hit a wall with this complexity.
So people like Greenwood and colleagues are asking, is just describing these complex changes qualitatively, even in a diagram, really enough? Does it capture the dynamism?
It's a fair question. It is like trying to capture a flowing river with a static photo, like you said earlier. You get a snapshot, but miss the movement.
So if the old models are like static photos, are there ways to make them more like, videos, more dynamic?
That's the hope. The researchers behind the article we're looking at argue that while the dominant types might fall short, more flexible, dynamic models are possible.
Okay, so it's not about ditching logic models entirely, but evolving them. And they look at this in practice.
They did. They studied the rollout of a patient experience toolkit PET across 6 different hospital wards, a complex intervention in different settings.
And they used this to test different logic model types.
Exactly, to see which type could best handle the real-world complexity. And based on this and a review of literature, they propose a typology, different kinds of logic models.
Okay, let's break down this typology. What's the first type?
Type 1 is the most basic. Really just lists intervention components and the expected outcomes. Think of the W.K. Kellogg Foundation models. Useful for initial planning, maybe, but very light on context or the how.
Simplest. Got it. What's type 2?
Type 2 models bring in context. They show factors that might help or hinder the intervention. Interestingly, the initial model for the PAET study was a type 2.
So they acknowledge the environment matters. How do they show it?
Often linearly. Inputs lead to activities, to outputs, to outcomes, and context is shown as sort of external forces acting on that line. enable, or constrain.
Still pretty linear, though.
Yeah, that's the limitation. They struggle to show how the intervention itself changes because of the context. Even fancier system-based versions often keep intervention and context quite separate.
So you'd probably need a long story next to the diagram to explain all the adaptations and feedback loops that the picture itself doesn't show.
You often do. And that need for narrative justification flags that maybe the model type isn't quite capturing it. Which brings us to Type 3 logic models.
Okay, how do these differ?
Type 3 focuses more on the connections between the elements. How one thing leads to another within the interventions theory. Think driver diagrams used in quality improvement.
Can you just give an example?
Sure. Reducing hospital infections. A driver diagram might show how better hand hygiene that's the driver achieved through, say, more sanitizer dispensers and training activities leads to less bacterial transmission, an intermediate outcome, which finally leads to fewer infections, the ultimate outcome. Clear arrows showing those causal links.
Ah, okay. So mapping the specific hypothesized pathways of the intervention.
Exactly. Very useful for testing those specific hypotheses and getting practitioners to agree on the core mechanisms. But
there's always a but.
right. They still mostly focus on the intervention itself and struggle when that intervention needs to look very different in different places. They might allow for alternative causal strands, some limited variation, but it's often not enough for truly adaptive programs.
So this leads to the big question for healthcare improvement folks. Can any of these models really describe something that might genuinely take a different shape every time it's delivered?
And the researchers suggest that for types 1, 2, and 3, the answer is often, no, not really, not adequately. But they propose a type 4 logic model could be the answer.
Type 4. And this connects to the Paris model you mentioned.
That's right. Paris promoting action on research implementation in health services. Now, Paris isn't strictly a logic model itself, but it's a framework that heavily emphasizes how getting research into practice successfully depends on this dynamic mix of evidence, context, and crucially, facilitation.
Facilitation, the support and guidance provided.
Exactly. It inherently gets that adaptation, context, and support are intertwined.
Makes sense.
And the researchers saw this focus in Paris was highly relevant to complex interventions like the PEAT study, where facilitators were actively adapting their approach on each ward. Paris can also be used proactively to plan implementation.
So this suggests a new role for logic models in complex situations. Less of a rigid blueprint for everyone.
And more of a guide for the facilitators.
Yeah, helping them navigate the context.
Precisely. So the researchers took ideas from Paris and integrated them into a more traditional logic model structure to create their Type 4 model for the PE intervention.
Okay, what did that look like? What was the goal for someone using the PE toolkit later?
The aim was to help future users plan implementation, to prompt them to really assess the context before starting and guide the facilitator on how to respond to different enabling or challenging factors they might find.
So less prescriptive, more about equipping the facilitators to think and adapt locally, like a navigational chart rather than a fixed route.
That's a great analogy. Now, they acknowledge this Type 4 approach isn't perfect. It's more abstract, so maybe less specific guidance day to day. It relies more on the facilitator's judgment.
And because it assumes variation.
It might be less useful for that initial stage of getting everyone to agree on exactly what the intervention is. It's not ideal for building that initial consensus across diverse groups who want a single, clear plan.
So maybe not the best tool for generating initial buy-in everywhere?
Perhaps not, but its strength is handling the variability. And from building this Type 4 model, the researchers distilled some key principles for advancing logic models to better handle complexity in healthcare settings.
Okay, let's get into those. What do we need to do to make logic models better suited for this complex reality?
First principle, robust qualitative research. You need solid qualitative data from across different sites. They recommend using structured analysis approaches like the framework method.
How does that help?
It helps manage the data systematically. You can use logic model categories to structure your analysis matrix and then test and refine the model based on what themes actually emerge from the real-world data. It's iterative.
So the model evolves based on evidence from the ground. It's not just theory.
Critically important. You test it against empirical data. You might start with a Type 4 outline if you know it's complex, or experiment as you go.
Okay, what's next?
Second, the role of narrative. The story you tell about the intervention theory, explaining the model that remains fundamental.
The diagram isn't enough on its own.
Never. And if your narrative has to keep explaining why simpler models don't work, that's a big clue. You probably need a type 4. They also suggest focusing the model on core functions or mechanisms of the intervention, not hyperspecific activities.
To allow for that flexibility in how those functions are achieved.
Exactly. Gives more room for variation. Third principle, experiment with dynamic shapes and arrows.
Moving beyond just boxes and straight lines.
Yes. Think about Venn diagrams, dotted lines, double-headed arrows, feedback loops, visuals that can express contingency, dynamic relationships, adaptation. The Type 4 PET model used a Venn diagram for roles and dotted arrows for contingent outcomes and feedback, trying to overcome the limits of the earlier model.
The visual language needs to catch up with the complexity. Makes sense.
Fourth, show the full spectrum of contextual moderators. Type 4 models see interventions as events in systems, so you need to map out the context thoroughly.
Not just one or two factors.
Right. All the relevant factors, inner ward dynamics, outer organizational pressures, maybe micro, meso, macro levels. Displaying this range helps frame discussions about adaptation and even how to make the context more receptive.
So the context is just as important as the intervention itself in the model.
Absolutely central. Fifth principle, target the facilitators. Since these interventions adapt through facilitation, the logic model should primarily be tools for them.
Guiding their assessment of context and strategy development.
Exactly. Help them think through how to tailor the approach. This could be key to scaling up complex interventions more effectively. The audience shifts.
From broad stakeholders to the implementers on the ground.
Yes. And the final principle is about incorporating differences of opinion.
How so?
Type 4 models might be less about forcing consensus. In complex situations, maybe acknowledging different valid perspectives is more realistic and useful.
Instead of trying to get everyone to agree on one picture.
Right. In the PE study, people had different views on the toolkit's importance or which contextual factors mattered most. A Type 4 model can allow for the possibility that multiple views might be right, depending on the specific setting. It reflects the complexity rather than trying to erase it.
That feels like a significant shift in thinking about models and agreement.
It is. So, wrapping up this deep dive for everyone working in medical education or healthcare improvement. The main takeaway is that our traditional logic models, while useful, they do have limitations with complex adaptive interventions.
They struggle with that dynamic interplay between the intervention and context.
Exactly. And the proposal isn't to throw them out, but to evolve them. We've discussed this typology, moving towards more flexible, dynamic Type 4 models.
Models that explicitly try to capture that interaction between the intervention, the facilitation process, and the context.
Right. And this changes how we might use these models, too, less as rigid blueprints for achieving consensus across all sites.
And more as tools to guide facilitators, help them understand the context, and adapt effectively.
Precisely. It's about embracing the complexity. And, this whole discussion makes you think beyond just healthcare research, doesn't it?
How so?
Well, this increasing recognition of complexity everywhere, in policy, in social change, education, it really prompts a question for all of us. Might we need to fundamentally rethink many of the traditional models and frameworks we rely on, moving towards approaches that are inherently more adaptive, more context-aware, more equipped for a dynamic world?
A very provocative thought to end on. How do our tools need to change as our understanding of the world gets more complex? Lots to consider there.